The reason I chose this subject to talk about is because I've been getting a lot of questions over the last few years about the changes that have gone on in prostate cancer grading. What are they? Why are they? And did they really make an impact? So let's delve into that just a little bit here. The grade of a tumor is really the phenotypic expression of a tumor's biologic aggressiveness. What we see especially reflects how it is expected to act. It reflects the degree to which the cancer cells deviate from normal, using that as a reference, in terms of cell-to-cell interactions, their invasiveness, and their overall morphology. And they're directly proportional to the risk of metastasis, therefore reflects the biologic aggressiveness. The first ever grading system was that of Broder's, done back in the 40s for squamous cell carcinoma of the lip. Still not going. I'm going to go down here. Use this little trick. Okay. The first grading systems for prostate cancer truly tried to reflect Broder's system, looking at the nuclear detail. There was the GATA, the NPCP, the Bocking, the Mastophy, all looked at nuclear grading, and it didn't work very well. It didn't work as well as it did for squamous carcinoma. So a number of groups started to look at architectural stuff, and the most famous, the one that has stuck, is that of Don Gleason. What Don Gleason did, he was an artist as well as a pathologist, and he was fascinated by all the different architectural patterns that you saw in prostate cancer, and he drew what he saw, grouped them into patterns, and gave them to a statistician and said, does any of this make sense? Turned out that it made great sense, and that was the whole basis for him creating his grading system. The one that we know now, the most famous drawing that came out of his publication of 1992, is the one here on the right, where he looked at all the architectural patterns and he grouped them together. And basically what he was showing is that the morphology, the architecture of a prostate cancer reflects two basic properties. Its resemblance to normal prostate and its degree of invasiveness. So if you look down up here, number 1 here, 1 through 5 are the different patterns here. 1 reflects a tumor that is made by acini that are lined by cells that look very much like normal prostate cells. In fact, later we found out they kind of are normal prostate cells, and we'll get into that in a minute. And notice they have this nice rounded feature to them, meaning that they're not invasive at all. They just kind of expand. You go to the other end of the spectrum, the Gleason pattern 5, and now you have cells that are complete anarchists. They don't hold hands. They don't make glands at all. They don't make acini. They're just sheets, individual cords of cells, and they're raggedly invasive, destroying everything in their way, and of course everything in between. And that came up with the 5-tiered system. He also noted in his system that prostate cancers often had more than one pattern. And he created the score, the old Gleason score that we still use today, which uses the most common pattern within a tumor and the second most that were grouped together. So if a tumor was 70% looks like this, but 30% of it looked like this, you'd call it a 3 + 4, or a score equals 7. Now Gleason himself made the first changes to his own grading system. After validating it in literally thousands of individuals afterwards, he did his own expansions, creating the pattern system that you see here. However, I want to note a few things that still bothered Don Gleason when he did this. Notice that there are patterns that bridge this dividing line between, say, 3 and 4. There were those patterns that he couldn't really get his head around in terms of statistical analysis to show, should they be lower grade patterns or should they be higher grade patterns? So let's get into that a little bit later. Since he discovered and spread this very well-used grading system, it is shown to be probably the best prognostic factor for prostate cancer that we have. Multiple studies have shown this. This is a really good one, I say. This is almost 24,000 people across 5 famous institutions looking at mortality. And you can see that in all age groups, as you tier up and really notice that the business end of prostate cancer, whoops, can I go back? I hit the wrong button. That the business end of prostate cancer is really down here in the 4s and 5s. So with that in mind, you notice that as the relative percent of pattern 4 increases, so does prostate cancer-specific mortality, which is in black here, over all age distributions here. And competing mortality here is in gray. So it really shows to be quite nice as a prognostic factor. However, there are still problems with the Gleason system. Most low-grade patterns we know now are benign. How do we know that? We had tools that Gleason didn't have. We have things that stain for basal cells that show that those tumors are more like adenoses. They're really not invasive tumors at all. Confusion on how to grade cribriform. That was the patterns that kind of bridge both pattern 3 and pattern 4 and really weren't categorized very well by Don Gleason himself. Certain variants were never described in the Gleason system, like ductal carcinoma, etc. And there were tumor sampling issues. When Don Gleason did his original studies, they used very large caliber needles, and even some of them were done on transurethral resection specimens. They didn't have the fine needles that we use today. Does that make a difference? Well, it can make a difference, because when you're talking about smaller caliber needles, you're sampling a relatively smaller amount of tumor. And therefore, the pattern recognition of primary and secondary may be influenced by that. So in 2005, it's well known now that the International Society of Urologic Pathologists, of which I'm a member, met to address these issues and look at guidelines for grading prostate cancer. Now, there's this misconception that we all met and changed everything. No, we really met to look at our individual experiences based upon data. And that is really where these recommendations came from. So the recommendations were based upon 80 pathologists, genitourinary pathologists from all around the world, getting together and using their experience and data that was presented at the meeting to really help with this. And some of the things that were done at that time is we all agreed there should be restrictions on assignment of very low grades, pattern 1 and 2 on biopsies. That's why you just don't see it anymore, because a lot of these were found to be benign, and 2, almost all of them were upgraded at the time of prostatectomy. So it wasn't very informative to have very low grades on a biopsy. And you can see that there is data behind this. This wasn't just a change. This wasn't opinion. This is stuff that occurred over time, long before we actually met. We noticed, this is stuff from the Capture database, that Gleason 2 through 4 diagnoses at biopsies went from about a third of cases back in the 80s to about 5% by the time you reach the turn of the millennium. So we were already starting that shift, and that shift was really based upon experience. We had a broader definition of pattern 4, really including things like poorly formed glands and fused glands. Now that sounds like we solved that problem, but that actually created more confusion, because when you use a term like poorly formed and you throw it out there, it leads people to have interpretation of exactly what a poorly formed acinus was. And we'll come back to that. We addressed that later. We used guidelines for assigning grade to cribriform patterns of cancer. Unfortunately, at the time, we didn't have good data about cribriform cancer, and I will show that that has changed. We'll address this again during this talk. We really didn't have good data at that time. So we kind of left it the way Don Gleason did, that, oh, if there were small little bits or regular bits of cribriform tumor, it should probably just be grade 3 and not change things. But most cases are large areas of cribriforming and are irregular, so they should probably be called grade 4. Really lacked data at the time, and we now have more data to address that. And then the grading of histological variants, and this was all based upon survival data, looked at things like ductal carcinoma, signet ring carcinomas, et cetera, and neuroendocrine, and really put them as high-grade tumors, because we had experience now that these do poorly. Probably the biggest impact, however, was this last point, and that is the grading of biopsies. Remember, the biopsies have gotten smaller, with minor amounts of high-grade tumor on it. What do we do with those? And the recommendation was thus: if you've got any high-grade pattern present in a biopsy, it should be part of the Gleason grade. So, and this was not done uniformly across the world. Minor components were usually ignored. And so this was a major change. So if you had greater than 90% pattern 3 and less than 5% of a pattern 4, you should score that as a 3+4 regardless. Don't call it a 3+3. But don't do that in reverse. Pattern 3 is inconsequential. So if you've got 90% pattern 4, ignore the 3 and just call it a 4-4. And if the worst grade is not the predominant or the secondary, now this happens very rarely in a needle biopsy the size that we have, but sometimes it does. So if you've got a tertiary component, that should be included if it's of higher grade. So if I've got 70% pattern 3, 25% pattern 4, 5% pattern 5, I should call this a 3 plus a 5, not a 3 plus a 4. Why was this? There was data behind this. Some of the best data comes out of Johns Hopkins. They looked at low-grade tumor with a tertiary, remember less than 5% of a higher grade pattern, in this case 4 or 5, and they showed that if you had that small amount that it actually behaved like a Gleason 7. You should have included it in the Gleason score to begin with. Even if you have a Gleason 7 with a little bit of tertiary 5, it's going to behave worse and so should be included. From the other side of the country, the Stanford group also came to the same conclusion in a different way. They basically said, you know, what's really important about prostate cancer is the business end. Gleason patterns 4 and 5. And as your relative percent of the 4 and 5 goes up, your fail rate goes up. So that's what we really should be paying attention to, is how much 4 and 5 you should have. Well, the obvious thing that would do, and was confirmed, and that is that you would have grade inflation following those recommendations. And in fact, this is a study out of Canada that looked at their grading practices of the same group of individuals, same pathologists, grading cases before the 2005 consensus conference and after it. And you can see that in their biopsies, Gleason 6 patterns did go down, Gleason 7s did go up, even 8s went up. So there was a grade inflation, everything moved up. And they actually looked at where that occurred, and it was not in the primary Gleason pattern, it was in the secondary Gleason pattern. So the small amounts of higher grade tumor did make a difference and was impactful in this. Now, what does this mean? This is, hang on a second, there it is, the one I want. If you look at, did this have a meaningful impact, you need to look at a study like this. This is out of Harvard, an amazing study because they went back to almost 700 patients that they had graded before the 2005 consensus conferences, and they regraded them using all the rules of the 2005 consensus conference. And this now is prostatectomy data. You can focus over here on the right side here. This is the original scores as given. And they looked at prostate cancer-specific mortality in their database over time. And you can see that mortality occurred over all grades. Here are the grades: 2 to 5, 6, 3 plus 4, 4 plus 3, 8, 9 to 10. And they had mortality over all of these grades. Even very low grades had a real, small, but real mortality rate, and it all over the place. And in fact, if you look at this, 4 plus 3s did actually worse than if you had Gleason 8 in the original scheme. By rescoring them, which is what they've done here, they've recategorized all of these tumors. And yes, there was a shift towards higher grades in the entire population. But look what it did with the mortality rate. Smoothed out the mortality rate and showed that if you have Gleason 6 or below using the modified system, you had absolutely no mortality within their database. And this is the hazard ratio as you go up in Gleason tiering. So it really did have an impact on our ability to prognosticate. Well, we met again. The ISUP met again in 2014, and we did things a little different this time. This time we included a lot of GU pathologists from around the world, but we also included a number of clinicians, urologists, medical oncologists, radiation oncologists from 17 countries to be a part of this and weigh into what we were doing. We tackled a few things that were left unaddressed in 2005 or needing reconsideration due to new data. And we did some clarification on the classification of morphologic patterns. We clarified to make a more stringent definition of our pattern 3. Why? Because we really thought pattern 3 are those tumors that you want to be able to have the option of doing active surveillance. You don't want that to be contaminated with tumors that are likely to progress. And what we really tackled was this inclusion of all cribriform and glomeruloid patterns. So now we were armed with some data about the cribriform morphology. What we left in 2005 was that these small cribriform patterns could be left as pattern 3. I know it looks about the same size as this pattern 4 over here, but the resolution is twice as high. This would be a large, irregular pattern of cribriform. We call that 4. This is small. We would call it still 3. And if you look at glomeruloid, it kind of resembles the small. We'll just call it pattern 3. That's confusing. And it wasn't data-driven. And so a number of groups, including my group, got together and tackled this problem. This is our data. I know there's a lot of numbers out here. I just want to focus your attention right there. This is looking at cribriform morphology and biochemical recurrence in patients that have that morphology. And what we found was the highest odds ratio for PSA failure fell in those tumors that were cribriform, far more than the individual pattern, which is your grade 5, your high-grade pattern in the Gleason system, regardless of whether they were small or large or even amount. If you had it, it was worse. And this is the European data looking at it as well. They tackled the problem a little differently. In about 161 patients, they looked at having cribriform, yes or no, any cribriform, small or large, within them. And they showed that if you've got the cribriform morphology, that you did worse in terms of biochemical recurrence, but also metastasis-free survival with the odds ratio of 8, disease-specific survival, and even overall survival. So the cribriform was really important for them. They expanded their study a year later to look at over 1,000 patients. And in this study, they looked at the various categories of Gleason score: 6, 3 plus 4, 4 plus 3, 8, 9 through 10, on the entire cohort here of over 1,000 patients. And what they found was if you've got cribriform morphology, regardless of your Gleason score, even if you've got 9, 10, if you have the cribriform morphology, you did worse with a hazard ratio here of 3 over background. So the cribriform morphology is clearly a high-grade tumor. And the ISUP then redrew, if you will, the boundaries for the Gleason system. This is the old pattern that Don Gleason drew. They drew this, having more stringent definition of what we call low grade. They had to be well-formed acini, and anything cribriform fell beyond the pattern 3 and into the high-grade patterns here. And finally, we did this, and this has probably confused people more than anything, was this new prognostic grade classification. You've seen the prognostic grades. How many people get those? Do you see the prognostic grade groups of 1 through 5? Hopefully it's starting to get around. What does that mean? Is that a whole new grading system? No. All it is a way of classifying the grade patterns into things that make sense. Does it make sense to have a 2 to 10 scaled grading system for prostate cancer in today's world? Probably not, because Gleason score 6 has a favorable outcome. Yet Gleason score 6 is halfway between a score of 2 and 10, which is our parameters here. So when a patient looks at this, it contributes to the reluctance to do active surveillance, because that's right in the middle. It sounds like it's an intermediate grade. Gleason scores of 2 through 5 are rarely used. They're not prognostically different from grade 6. It's the amount of pattern 4 and 5 that is important for prognosis. So we need a grading system that could better allow us to tell patients by classification who is an appropriate candidate for active surveillance. And that's where the grouping came in. And the prognostic grade groups look at Gleason scores of 6 or less as prognostic grade group 1, the best that you can have. 3 plus 4 is 2, 4 plus 3 is 3, 8 is 4, and 9s and 10s are 5. And if you'll notice here, that increasing prognostic group really reflects the amount of the high-grade tumor, patterns 4 and 5, relative to the amount of 3. Okay, that's what it is. So we adopted to vote this 5-tier system. There was 90% consensus. It was almost 100% consensus from the clinicians that were in the group. I think there was just one who wasn't sure we were doing it right. We also recommended that although we can do these as tiered classifications, that there may still be gray zones, and that we should really give the percent of high-grade patterns within classes 2 and 3 to show how much is really there. And all modifications that we recommended in terms of how to grade should be used. So a number of groups have now looked to validate this study. This comes out of the European data, which looked at the impact of the 2014 grade groupings. And as you can see here, the grade groupings hazard ratio for biochemical recurrence is nicely exponential as you go from 1 up to 5. You also looked at the different grade groups in terms of their corresponding with things like lymph node metastases in red here, seminal vesicle invasion in dark gray, and extraprostatic extension in light gray, and notice that it goes up as your tiers go up. This is also from the European data. This is from the National Prostate Cancer Registry in Sweden, and they looked at the grade groupings as shown, and you can see here the hazard ratios for biochemical recurrence over time. This is the biopsy grade as a tier for hazard rate for recurrence. This is the radical prostatectomy grade as a hazard ratio for recurrence, and even after radiation therapy. The radiation therapy group really looked at this. This is the RADAR trial, and looked at the ISUP group. And again, they showed that the ISUP grades were important in terms of predicting distant metastases, PSA progression-free survival, and prostate cancer specific mortality. And they went on to actually look at the two modifications. This is the only group that I know that has done this. They compared what if we just did the 2005 modifications that were recommended with the 2014, and that they actually showed that the 2014 modifications for all of these endpoints, metastasis, biochemical recurrence, and overall survival, was significantly improved as the C index was significantly improved using the modifications of the 2014. And then here's at the community practice level. This is from the SEER database, looking again at prostate cancer specific mortality. You can see it tiers up nicely with the different grade groups, and even overall survival tiers quite nicely with the different grade groups. Finally, from a molecular standpoint, if you look at the different grade groups, this is grade group 1, 2, 3, 4, and 5, and these are copy number alterations that occur within tumors of those different grade groups. And you can see as you progress from 1 to 5, you see an increase in the number of copy number alterations that occur over the grade group. So it's been validated at multiple levels now. I do have a couple of ARS questions. Is that possible to pop those up? So these are ARS questions. Everybody has in front of them a little calculator thing, this little button thing. Now, by pressing that button, you can enter your answer for looking at this. So here's the question. Cribriform carcinoma of the prostate has it been graded as Gleason pattern 3, has been graded as Gleason pattern 4, has been associated with a high risk of biochemical recurrence and metastasis, or all of the above, or none of the above. So 1 through 5. So cue in what your answer is, and we'll summate that in just a few moments. Is it not summating yet? We're getting there? Oh, okay, so it's not working. All right, so we're not working right now. All right, well, let's actually, if we go on to my conclusions, the answer's there. Okay, that's fine. So, in conclusion, cancer grade is a strong indicator of prognosis. It always has been. That's its goal. And the grading system for prostate cancer must be able to be ideal to distinguish tumors that require immediate treatment for those that can be candidates for AS. The Gleason grading system itself has undergone many refinements to produce its predictive accuracy, the last one just a few years ago in 2014. The presence of cribriform cancer, new data, may offer independent prognostic information now. And so we really recommend that if you see any cribriform cancer in a biopsy, that actually become part of the process. So if I say a patient's got a 4+3 carcinoma, I'll actually say with a cribriform cancer component in it. And the 5-tier prognostic grade groupings proposed by the ISUP offer excellent prognostic stratification. It's based upon the gleading system, it's easily understandable, and validations have already confirmed its clinical utility. So the answer was all of the above for the cribriform cancer. It's been graded as 3, it's been graded as 4. It clearly shows prognostic information in terms of even prostate cancer-specific mortality. And with that, I will leave you. Thank you.